Even though pancreatic cancer is an individualized disease in terms of what happens to people that have it, have there been any comprehensive studies of long-term survivors to see if there's some commonalities that can be used beneficially in the future, either in terms of research or in terms of patient care?
I think that so far we don't really have that information yet, because it's really not until now that we've begun to see long-term survivors. But there are a lot of groups that are interested in taking the tumors that have been removed and comparing those tumors between the folks that lived for a long period of time to those who lived a shorter period of time, and seeing if there are differences. But we're still finding our way on that. Yeah.
Are there any statistics that show that people who do not have surgery have any longevity expectations?
I think we do have patients who are many years out with inoperable pancreatic cancer. And it all has to do with how your cancer responds to the combination of drugs that are chosen. I think we commonly tell folks that the decision to start chemotherapy or to start a particular treatment regimen is not a final decision. The treatment team that's caring for you needs to be flexible and change paths depending on how things are going. So if the tumor marker changes, or if your CT scans aren't really showing much of a response, then a new decision needs to be made, a new decision on what type, change the drugs, go a different direction. Because now we do have different combinations of drugs that can be used. There have been some advances, especially for folks who have unresectable or advanced disease, that have happened over the last 24 to 36 months.
Do you have any statistics differentiating between neuroendocrine pancreatic cancer and other forms of pancreatic cancer?
Well, there definitely are two different diseases, pancreatic adenocarcinoma and neuroendocrine cancer of the pancreas, or pancreatic neuroendocrine tumors. Sometimes we call it PNET, P-N-E-T. They are different, come from different cells in the pancreas, and the timeline of how patients do are different. The treatment strategies are different. Generally speaking, patients with neuroendocrine tumors of the pancreas do better. They have longer survivals. And even when they have metastatic disease, many of them live for many years, untreated sometimes even, with metastatic disease. So there definitely are differences between those two diseases, and a determination needs to be made of which one of those you have so that the correct treatment strategy is offered.
Not a lot was said about CyberKnife. Is that more of a localized chemotherapy? And if it is, why isn't it used more often for, to get less side effects?
The experience with a CyberKnife or intraoperative radio frequency ablation, or using electroporation, where you actually sort of use electricity to kill the cancer cells, that is still very early on in the experience in the country. It's not clear that it offers any survival benefit, and it's a big deal to be zapping the pancreas in the operating room. There are a lot of blood vessels that are in that area that are important for other organs, so it's completely really investigational at this point. So much about what we do every day in our lives, almost everything we do is about connection. There's no doubt that we connected today, and I congratulate all the panelists on their success and wish you the very best going forward.